Hello, my dear students. Welcome on this new session. And we are doing the endocrine system and we are into the corticosteroids. And as you see here, I've shown you some preliminary things, some basic thing which you might have done in your physiology and biochemistry. Hypothalamus, shown at the top, is called the master of endocrine orchestra. And hypothalamus conducts the whole orchestra of the endocrines. Hypothalamus is going to release what's called corticotropic releasing hormone, or you can call it ACTH RH. That's adrenocorticotropic hormone releasing hormone, or you can call it corticotropin releasing hormone. So this is a releasing factor coming from hypothalamus. It acts on the anterior pituitary, and in response to this, the anterior pituitary secretes ACTH, adrenocorticotropic hormone. Tropic is going to be the substance acting on a particular target tissue. And what's the target tissue? The target tissue is the adrenal cortex. And in response to the stimulation from the adrenal cortex is going to secrete the corticosteroids. So that's the positive effects happening due to the release of the corticotropin releasing hormone. Now, in this, there exists an amazing negative feedback. The levels of the corticosteroids which are there circulating in the blood can be sensed by the pituitary, and the pituitary has to decrease accordingly the amount of ACTH. The levels of the corticosteroids and the ACTH have to be sensed by the hypothalamus, and if these levels are high, there are large amount of steroids or ACTH is going to put a negative feedback on the hypothalamus and is going to decrease the CRH or ACTH RH. When this is decreased, ACTH will come down and the corticosteroid secretion from the adrenal cortex will come down. So that's called the negative feedback which exists in the endocrinal system, and we're going to make use of this particular concept to understand few important things about corticosteroids. Let's go to the first slide. Corticosteroids are secreted by the suprarenal gland, that's the adrenal gland, and the adrenal cortex secretes the steroids. Zona glomerulosa of the adrenal cortex secretes aldosterone, and zona fasciculata secretes the glucocorticoids and the sex hormones. I hope you know aldosterone is a mineralocorticoid, and the zona fasciculata secretes glucocorticoids and sex hormones. So aldosterone and glucocorticoids together we call it corticosteroids. What's the mechanism of action? Steroids have got a typical receptor. Whenever we say receptor, it means something which is going to receive. And if you want to receive someone, you have to be at the door. And naturally, most of the receptors are present on the cell membrane. But this is an exception. The corticosteroid receptor is a nuclear receptor. Of course, when the glucocorticoid will come, it will combine through the cell membrane, it will come inside, and the elements or the components which are designed for combination, they undergo dimerization, and after the dimerization there is activation of what is called GRE, glucocorticoid response element. When this is activated, this leads to gene transcription, and the gene transcription progresses to the protein synthesis, leading to the specific effects. I hope you remember nuclear receptors are common for many of the hormones which have got steroid type of structure. For example, estrogen receptor is a nuclear receptor, androgen receptor is a nuclear receptor, and this one, that's the glucocorticoid receptor. And whatever I showed to you on the board is coming again on this slide. Hypothalamus secretes ACTH RH or CRH, pituitary secretes ACTH in its response, and the adrenal cortex secretes the steroid, and that's the negative feedback. When we are discussing the discussion of corticosteroids, this HPA axis is a very important issue, and we are coming to the important thing that happens when the patient goes on receiving corticosteroids by a systemic route for a long period of time. I am trying to explain to you what happens and try to imagine. Suppose a patient suffers from a skin disorder and is put on corticosteroids for long term, and every day he is going to receive the corticosteroids. Look at this. The glucocorticoids are coming to the blood and they are circulating. If you ask the adrenal cortex, hey, adrenal cortex, can you differentiate between the glucocorticoid which is your own and the glucocorticoid which has come from outside? The cortex obviously will say no. The cortex cannot understand which one is the steroid given exogenously and which one is the endogenously secreted. Naturally, the cortex feels that there is a large amount of steroids, so it's a kind of negative feedback for the adrenal cortex to decrease its amount of steroid. If the substance is already present, why pour it and why secrete it? Similarly, if you go to the pituitary, when you are given corticosteroids from outside, these corticosteroids are going to act as a negative feedback to the pituitary, and pituitary has to decrease the ACTH. The next level of negative feedback is, if the corticosteroid level is high, the hypothalamus has to decrease the amount of CRH or ACTH-RH. So what happened? Because you gave long-term steroids to this patient, the steroid levels in the blood are already high, and this is why the hypothalamus is suppressed. So the ACTH-RH comes down. In response to this, the pituitary secretion gets suppressed. So ACTH comes down, and slowly the adrenal cortex will stop secreting its own corticosteroid. So I hope you understood the word suppression. Suppression of hypothalamus H, pituitary P, and the adrenal cortex is A. H, P, and A. I call it suppression of the HPA axis. So if you give glucocorticoids over a long period of time, you get suppression of HPA axis. This is what I have written on this slide. Chronic administration leads to decrease in the endogenous steroids, and then the body goes on depending on the exogenous or outside steroids. Now look, listen to me. I showed you already on the slide. Now let's talk and understand. Now, if you think of this particular patient and you go inside and visualize how much is the steroid secretion, endogenous, from within the body, almost no, because you suppressed the HPA axis. In this situation, in a particular week, if this patient stops taking his exogenous steroid, what's going to happen? It's a sudden abrupt withdrawal, sudden abrupt stoppage of the exogenous steroid. And when this is happening, the things here happening, they are not instantaneous. You gave a steroid for 4 years. You cannot expect the adrenal cortex and pituitary and the hypothalamus to understand that you stopped your corticosteroids from outside, and you cannot expect them to secrete their own secretions within a fraction of a second or fraction of a minute. And what happens is, I am putting it in my story language, is hypothalamus has long back forgotten how to secrete ACTH, and the pituitary has forgotten how to secrete, hypothalamus has forgotten how to secrete ACTH-RH, and pituitary likewise has forgotten the mechanism to go for ACTH secretion, and the adrenal cortex obviously since last 3 or 4 years is not secreting much corticosteroids, and naturally the body cannot cope with this stress, and it is as good as not having steroids in your body. Steroids are life-saving substances. Steroids play permissive role in most of the reactions, most of the events inside the body. And now you have brought this patient to a situation that the patient doesn't have steroids. And we call this situation as acute adrenal insufficiency. There is no glucocorticoid inside the body. What's the lesson to learn? If a patient is receiving glucocorticoids for a long period of time, you should not stop them abruptly. Whenever we think of steroids or glucocorticoids, let's go to the next slide. You always think of a disease. Is something coming to your mind? The patients who have large amount of steroids inside their body. How does this patient look? Do you remember anything you did in your physiology days? If you don't remember, I'll remind you: moon face, buffalo hump, fish mouth. Do you remember this? This is called Cushingoid feature, and glucocorticoids on long-term use will produce the same thing. That's the Cushingoid feature. It's going to produce many adverse effects also, and this is why if you give glucocorticoids to your patient systemically for a long time, your patient is going to suffer from lot of adverse effects. So it's not good to give your patient systemic steroids for a long period of time. So the first message, as far as possible, avoid glucocorticoids. This is what is written on the slide. Message number 1, try to avoid. Now there are situations in which it's easy to say avoid, but it's not possible. You need to give glucocorticoids by systemic route to the patient. Okay, you need to give. You give, start steroid for your patient, but keep it in your mind that I have to stop it as early as possible. So give it for minimum period of time. That's the second dictum written on this slide. If at all you have to give it for minimum period. Now you're giving it for minimum period is okay, but don't start with a very large dose. Start with an optimal dose so that the patient doesn't become dependent on the steroid. So continue with a small dose as far as possible. And the next dictum obviously is stop at the earliest. The earliest you stop the steroids is going to be better. And while stopping, please remember your negative feedback and the suppression of the HPA axis. When you want to stop it, don't stop abruptly. Don't stop suddenly. You go for tapering doses of the corticosteroids, which would take a long time depending on the length of the treatment which the patient has received, or depending on the dose which the patient has received. You can take 1 month to 6 months variably to gradually taper the dose of the steroid so that you give a chance to hypothalamus, pituitary and adrenal cortex, the whole system, to come back in play, and the system will regain the function and the patient will not suffer from acute adrenal insufficiency. I hope you're going to remember this discussion. With this, I take you to the next slide and we start discussing the actions and adverse effects of glucocorticoids. This is some interesting chapter where you can think about the action and you can extrapolate or you can explore the adverse effect. You can build up the adverse effect based on the action. I'm not exactly saying it's like mathematics because medicine is not mathematics, but still, if you know this is the action and if this action gets exaggerated, probably you can derive the adverse effect. So I'm trying to break the traditional way of teaching and telling you all the actions one by one first, then coming to the adverse effect. No, you're going to do both the things hand in hand. The left column is going to tell you the action, and we'll discuss about the action, and immediately we'll think what will happen, what will be the adverse effect of this. Let's start with the first row, that's carbohydrates. What's the effect of glucocorticoids on the carbohydrate metabolism? I said they are life-saving substances. So they are coming to your help, they are going to come to your help whenever your body is in trouble. Simple way to remember. So if your body has less blood sugar, glucocorticoids are going to notice it and they are going to help you. They are going to break down the glycogen in the liver, that's called glycogenolysis. And the glucose will come to the systemic circulation. Next, if this is not enough, what they'll try to do is they'll try to facilitate the reactions in such a way that the sugar from non-sugar substances, that's the proteins and fats, will be obtained. Proteins will be broken down, fats will be broken down, and you will get the sugar, and this is called gluconeogenesis. So they will facilitate the glycogenolysis and gluconeogenesis, and the sugar will be brought to this systemic circulation. What we have to imagine is, if you keep on doing this every day and give the patient a long-term steroid for many days, what's going to happen obviously is, we are coming to the right side of the column, is the blood sugar levels will be elevated, what we call hyperglycemia, and this patient will slowly start showing hyperglycemia, and it will manifest into a situation like diabetes mellitus. So we say steroids are diabetogenic drugs. they facilitate the production of diabetes. And this is one of the common causes of what you call iatrogenic diabetes mellitus, the drug-induced diabetes mellitus. That's one. Number two, we go to the fat metabolism. The important action of the glucocorticoids is to redistribute the fat. So, on this slide I have just written redistribution. We are not going to the details of the fat metabolism. We want to know the gist of the matter. So the fats will get redistributed. And you can take a moment and bring in front of you the face of that Cushingoid feature which we are talking about, the moon face, buffalo hump and the fish mouth. So that straightway becomes the adverse effect which is on the right side. Moon face, buffalo hump, fish mouth, and it's called central obesity. The fat starts getting deposited in the areas where normally you don't expect the fat to be present, and something like a lemon stick appearance or the central obesity. So that's the adverse effect due to the fat redistribution. Number three, glucocorticoids have got the effect on protein metabolism, and the effect is anti-anabolic. So they are going to oppose the anabolism of proteins. And if you go to the right side, I have again written anti-anabolic effect on the proteins, leading to a negative nitrogen balance. So proteins inside the body are going to get wasted slowly because it's anti-anabolic effect. We go to the next box. The next row is the effect on calcium metabolism. A very typical effect. Look, what do? They decrease the absorption of intestinal absorption of calcium. So whatever calcium you're going to eat, the intestinal absorption is less. Second, they increase the renal excretion of calcium. So they don't allow the calcium to come inside, plus they are excreting more calcium. And number three, most important, they facilitate the resorption of bones. If you want to facilitate the resorption of bones, it's like bringing out the calcium from the bones to the blood and throw it off. That's the physiological action of glucocorticoids. And if you go to the adverse effect, we straightway can derive the adverse effect, and it's quite simple. Is the adverse effect of this will be increased bone resorption. It can lead to osteoporosis, spontaneous fractures, deformities, and if you give it in the growing age, there could be decreased linear growth. Steroid-induced osteoporosis is one of the most common causes of osteoporosis, and many physicians need to deal with this issue. So I hope you'll remember osteoporosis. Let's go to the next slide. The next slide, the first tissue which is being shown for actions is skeletal muscle. And I remind you the two effects of glucocorticoids. Number one, protein anti-anabolic effect. So under the skeletal muscles, I have again written protein anti-anabolic effect. So you can understand skeletal muscle is the tissue which is concerned with the proteins, and if this anti-anabolic effect is going to inhibit the anabolism of proteins, is going to worsen the effect on the action of the skeletal muscle. I remind you of one of the actions which also gets integrated here. That's the effect on calcium. Calcium is going to be less. So both these actions hand in hand work together on the skeletal muscle, and if you go to the right side, you will see the adverse effect. That's muscle weakness, and that's called myopathy. And this myopathy is predominant in the proximal muscles of the body. That's a very typical adverse effect of corticosteroids. That's called proximal myopathy. Let's go to the next row, the next box, the next line, and it's showing the effect on the stomach. And I hope you remember, you know that the glucocorticoids are most potent anti-inflammatory substances inside our body. Anti-inflammatory substances. And this is why you know there's a group of anti-inflammatory drugs called non-steroidal anti-inflammatory drugs, NSAIDs. Why are you calling them non-steroidal? It means you are giving a respect to the steroids, that they are in the first place, they are the major substances which are anti-inflammatory agents. This will help you to remember that glucocorticoids have got anti-inflammatory effect. And what I want you to remember out of this is, if they are having anti-inflammatory effect, how they must be producing it? By inhibition of prostaglandin synthesis. So if they inhibit prostaglandin synthesis, now we are coming to the discussion for stomach. Prostaglandin synthesis is decreased in the stomach also. And as you know, prostaglandins are cytoprotective agents in the stomach. When the prostaglandin synthesis is brought down, there's increase in the gastric acid production. So if you go on giving glucocorticoids for a long period of time, the gastric acid secretion is gradually going to be raised and it can start damaging your gastric mucosa. So there's hyperacidity, and let's go to the right side. The adverse effect here is peptic ulcer. So these patients are susceptible, are prone to get peptic ulcer, just like you get peptic ulcers with your NSAIDs, aspirin-like drugs, because the action is same, that's inhibition of prostaglandin synthesis. Let's go to the next action, and that's cardiovascular system. Prostaglandins are required for the physiological functioning of the body. They need to maintain the blood pressure, they need to maintain the blood volume, and if you have to maintain the blood volume, you should keep on retaining enough amount of sodium, and along with it enough amount of water should be retained. So if you look at the physiological actions, yes, glucocorticoids produce sodium retention and water retention, and this is going to produce certain changes in the heart. So I'm just writing it as cardiac changes. Now you think of the adverse effect. If this sodium retention keeps on happening over a long period of time, I'm writing on the other side the adverse effect, sodium retention, water retention, leading to edema. And this is why with glucocorticoids you can get edema. Second important thing, the blood volume is increasing, and when the blood volume is increasing, gradually you start getting increase in the cardiac output, and that leads to increase in the blood pressure. That's hypertension. And this is why, again, glucocorticoids, if taken for a long period of time, will slowly produce a rise in the blood pressure of your patient. And when there's a rise in the blood pressure, the heart has to pump against resistance, what you call afterload. So the afterload on the heart is increased. The preload is also increased because sodium and water retention is there, leading to increased blood volume, increased venous return. And this is how slowly you start putting an extra load on the heart. That is what I was calling as the cardiac changes, and it results into the cardiac hypertrophy. So the heart will be hypertrophied slowly, and then the worsening is going to start. There is going to get some ventricular changes, the changes in the ventricular geometry, what we call cardiac remodeling. So all this can start if steroids are taken for a long time. Next we go to the central nervous system. In the CNS, they do two things. Number one, there is water retention already, plus they have got an effect on the limbic system, and they elevate your mood. There can be aggression and there can be mood swings, and they also decrease the seizure threshold. The optimum threshold required for production of a seizure is decreased. The adverse effect derived out of this is, it's a very classical symptom if steroids are taken for a long time, is called steroid psychosis. So I talked about aggression, I talked about mood swing. From this you can remember psychosis. Second important thing is, water retention in the central nervous system can activate certain other reflexes, certain other events, and they can precipitate the other conditions. Water retention plus decrease in the seizure threshold. This is going to lead to precipitation of glaucoma, thus there will be increase in the intraocular pressure. So also, because the seizure threshold is decreased, you can get precipitation of epilepsy. Especially if the patient is suffering from epilepsy, steroids can precipitate it. The last thing written on this slide is ICT, and I am talking about intracranial tension. We already talked about the water retention, we talked about the edema in the periphery, so you imagine the similar things in the central nervous system. So I summarize the adverse effects on CNS as psychosis, epilepsy, glaucoma, and raised intracranial tension. We move on to the next slide, and next slide is reproductive system. And we already talked about zona glomerulosa and the other region, and you can understand the glucocorticoids produce effect on the reproductive system, and out of the secondary sex characters there is increased hair growth, and there are some skin changes which are produced by glucocorticoids. We try to make the adverse effect on the other side, increased hair growth, a physiological action. Adverse effect, it manifests as hirsutism. So hirsutism, acne and purple striae on the skin is a very typical adverse effect of glucocorticoids. On the next row, we go to a very important action. We already referred to this action, and the action was inhibiting the cyclooxygenase enzyme involved in the production of prostaglandins. So if the cyclooxygenase is inhibited, the prostaglandins are going to have anti-inflammatory effect. We talked of so many things, and you might have started getting a sensation that these are bad drugs. They are producing so many adverse effects. Please don't forget, they are potent anti-inflammatory drugs. So inhibition of cyclooxygenase leads to anti-inflammatory effect. They decrease the edema in the mucosa, that's decrease in the mucosal edema. And as far as the respiratory system is concerned, they decrease the reactivity of the bronchus. So I've written here a downward arrow, decreased bronchial hyperreactivity. So in response to various noxious stimuli, the bronchial smooth muscle going into bronchospasm is going to be controlled. So that's called decreased bronchial hyperreactivity or hyperresponsiveness. This is action number 10. And I'm not saying about any adverse effect right now. Wait a minute, we are going to the next action, and action number 10 and 11 we'll consider together. The next important effect of corticosteroids is on the immune system, and they produce T cell destruction, and they try to suppress the immunity. The destruction of the T cells is comparatively more than the B cell destruction, and this we call as immune suppression, immunosuppression effect. Is it good? You'll say yes, it is good. We can employ glucocorticoids for various diseases in which you are going to obtain the success by suppressing the immunity. So what I said was action number 10 and 11 together, let's consider. They are going to produce anti-inflammatory effect, and they are going to suppress your immune system. Naturally, for example, if there is an allergic reaction, glucocorticoids are going to suppress the allergic reaction. So they will have anti-allergic effect. But see, everything in the world is not good. The good and bad are the two sides of a coin. If you are producing anti-inflammatory effect, if your immunity is suppressed, and if I send a microorganism inside your body, what's going to happen? The microorganism will start producing its damaging effects. It will start producing the effects on various systems. And what your immune system is going to do? Because you gave corticosteroids, the immune system is suppressed. So it's not going to respond to these damages. Plus, even if the microorganism is producing some damage, you are going to have an anti-inflammatory effect. So you're going to feel better. So it's like masking of the disease. The disease goes on prevailing and the disease is masked. So I'm coming to the right side to say this anti-allergic and immune suppressing effect and anti-inflammatory effect together can manifest as delayed wound healing. Wound healing can get affected, and the patient can get more susceptible to infections. Active infections can fulminate, and the immune suppression effect is going to mask the infection. Most important infection which fulminates is the fungal infection, and please remember active infections like tuberculosis. So these were the actions and adverse effects of glucocorticoids, and I hope it was interesting for you to do the action and the adverse effect at the same time. By the way, I wanted to share something with you. I want to tell you something. Whatever country, whichever country you might be, whatever competitive exam you might be facing, maybe you are aspiring for your postgraduate medical education in some another country, or maybe you are returning back to your own country. Whatever competitive exam it might be, this topic, corticosteroids, is a high yield topic. And from my energy, I hope you appreciated and you understood that I have to do this topic thoroughly. So regarding all the lectures which you are listening, many of the chapters which are included are the high yield topics to specifically help you on your competitive exams, on your multiple choice exam. So I wish you good luck, and I request you go through these things seriously and put some effort on your own, and this is going to give you a great success on your exams. I think you enjoyed this. Glucocorticoids, we are going to continue on the next topic. I'm not going away. You go to the another session of glucocorticoids, the next session, to continue with the rest of the effects and the therapeutic uses of glucocorticoids. I think you enjoyed. I was also enjoying, and good luck.